Well, welcome to this most recent episode of the Akkad and Koka Report. Today we have the pleasure of having Dr. Rohin Francis here. Dr. Francis is coming on all the way from London. He's a Cambridge-trained cardiologist working at the Essex Cardiothoracic Centre, and he's also doing a PhD at the University College of London. I didn't get that right. CTC is what again?
Yes, that's right. Cardiothoracic.
It is a cardiothoracic center. Okay, great. So Rohin has been on my radar for a while because he's like he's of course a cardiologist at that's well respected and has a is at a place of high repute, but he also has an incredible social media presence and has a YouTube channel. And it's safe to say that he's kind of a YouTube sensation. He does a ton of fantastic educational videos, and for novices and amateurs like me, is really impressive to see how prolific he is and how good he is in terms of explaining concepts that are both cardiac and medicine related. So, Rohin,
well, at
thanks.
least if you're a novice, then I don't know what that makes me.
No, I'm definitely a novice. But thanks so much for coming on, Rohin. I appreciate it. I know your time is super precious.
Thanks for having me. Pleasure to be here.
Rohin, the last video, or not, I can't keep up, but the last YouTube video you did, one of the recent videos you did, was on a topic that's particularly germane to the times at the moment, and it concerns race in medicine. And I thought it was very well done because a lot of times you have, it's hard on Twitter with 140, 280 characters to really get into some of this stuff. And for most cardiologists like me, I'm average cardiologist, it's hard to flesh out some of the things, and we don't pay a lot of attention necessarily to some of the issues concerning race in medicine. It's there, it exists, I'm kind of aware of it. It's a problem, how significant a problem, what the scope is, what some of the background is. And you in 10, 15 minutes, again, a credit to how good of a communicator you are, kind of nicely laid out some issues. So I thought we'd bring you on to discuss not only some elements of the video, but also your story, because you are you have a story as someone of color in Britain who's become a cardiologist. So can we start with your story first? How did you get to where you are now?
A pretty boring backstory, to be honest. I was born in India, but I came to the UK at quite a young age. So I've done majority of my schooling in the UK, and I think that's an important point when talking about sort of discrimination in medicine, at least in the UK, is that it's difficult to separate discrimination in the medical profession with immigrant status, because the majority, well, at least historically, it's a bit different in recent years, but the majority of immigrants working in the National Health Service are from countries like those in South Asia, African countries. So I guess, we'll come on to that a bit later, but I just make the point that I don't feel I've faced the same hurdles that they do because I'm trained in the British system. And then, just the usual sort of route to cardiology. And
where were you born in India?
I was born in New Delhi, but I'm of Bengali origin.
And how old were you when you came to Britain?
I was about 5-6 years old.
Okay. And your parents came to Britain for what reason?
Well, my dad's English,
Okay.
and the main reason was my elder brothers got severe learning disabilities, and there just weren't the provisions in the 80s for someone like him. There wasn't really much of a support network. There wasn't any dedicated education. So we felt that he would be better provided for in the UK. That was the main motivation, really. It wasn't the usual kind of economic reason.
Is your dad a physician?
He's not, no.
Okay. What does he do, if you don't mind my asking?
He's always worked in the charity sector. So he was actually working for Oxfam in India when he met my mum, and then for many years he's been working in Bangladesh. He lives in Bangladesh now, and he's still involved with a lot of the infrastructure kind of work. As you know, it's very prone to flooding, so that's been the majority of his work.
I see. I see. And so when you came here, you came to UK, and you came to London, or have you moved around
Yeah,
within the
no,
United
I've been in
Kingdom?
London the whole time. Yeah.
Okay, so you came to London as a very young child. What did you what was your experiences as you know, a young brown kid? Did you come to a place where there was primarily white kids around you, or was it a very diverse place that you came to?
It was a pretty white neighborhood in those days. But I mean, London has been multicultural for quite a while. But certainly in my primary education, so under the age of 11 or 12, I was, I think, the only Indian kid in my class. Um, and again, I think, I don't feel like I have any major unpleasant memories. Now, in the kind of lens today that we tend to look at things and a bit more aware of them, I can think back at a lot of comments and things that at the time you just don't really even realize is an insult or is something that shouldn't be said. But I certainly would never frame my experience as one of particular strife, and people faced far worse
Yeah.
things than me. So no, I think I was fairly sheltered where I was, in a kind of quite nice residential area, but was certainly aware of things as I got a bit older.
Becoming a physician in the United Kingdom is not easy, and you're not, and not to minimize our colleagues, but and becoming a cardiologist is yet another kind of filter or whatnot, or extra steps that you have to take place. So is it fair to say it's pretty hard to become a physician in the United Kingdom?
Yeah, I think it's fair to say a lot of it's just sheer competition ratios.
Yeah.
So um, I'd like to think it's all a meritocracy, but there's clearly a lot of luck involved,
Yeah.
at all levels.
What's the proportion in the United Kingdom of so the term that is used a lot, I see by physicians in Britain, is BAME, right? BAME. So
Yeah.
what does that stand for?
So it's one of the frequently changing terminologies, but that stands for Black, Asian, and Minority Ethnic,
Okay.
and that seems to be the accepted term these days. I mean, for whatever, it's clearly useful to have terminology to discuss these topics, and I'm not too fussed what it is, but
Right.
I think. Uh, One of the things I was trying to highlight in the video is lumping all of those very disparate people into this one category. I think is not always that
Right.
helpful.
What's the percentage of physicians in the UK that are from the BAME group, would you say?
Um, so I've seen a couple of different figures. One, if you look at the NHS's overall healthcare staff, so the NHS is an enormous employer, but a lot of those employees are not sort of in the frontline staff. So if you look at all medical staff, but I think that includes nurses and other allied healthcare professionals, it's about 45%. So
Wow.
quite significant. But in terms of doctors, I've seen figures more like about 30 or 29%.
So 39 or 40% are BAME origin. That's really remarkable. I think that's somewhat similar, in terms, at least depending on which numbers you look at it. In the U.S., at some point, I think 40% of residents training are of some, of non-white or whatnot. So do you find? I mean, so it's highly competitive to become a physician, yet 40% of physicians are BAME origin. And I guess, are they mostly from Indian, Pakistani, Southeast Asian, and then less or so from African countries, or how does?
I wouldn't want to um, say anything categorical because but certainly, you know, an interest of mine for a long time has been the history of the
Mhm.
NHS and immigration to the UK for NHS reasons. And our mutual friend Saurabh Jha had asked me to write a piece about how doctors from in the Indian subcontinent have essentially completely propped up the National Health
Yeah.
Service in the 60s and 70s. So certainly, you know, there's historically a huge number of physicians that come from the four countries, Bangladesh, India, Sri Lanka, and Pakistan. Um, but yes, there are lots from Nigeria and Ghana as well. A lot of these are former Commonwealth countries. So these are countries where the British, they used to be colonies of Great Britain.
Right.
And in terms of nursing staff, you've got a similar pattern, many from African countries, as well as from the Caribbean.
So that raises one of the questions raised. By the way, your video is fantastic. I recommend everyone watch it. We'll have a link to it, you know, in the show notes. And you brought up a lot of different things. You know, certainly the one thing you brought up that I don't mean to at all ignore, and we'll talk about now if we can, is the fact that a lot of the front line, you know, people see me walk out in scrubs every now and then are like, oh, thank you so much for what you do. And you know, because of the whole COVID pandemic. I try to tell them as much as possible, like, really, I am not anywhere close to the front people on the front lines. You know, it's the nurses that are working with intubated patients that, you know, have to spend hours with patients. You know, the techs here, etc. I mean, they certainly are really on the true front lines in the way that I am not. And you know, nicely brought that up, and the fact that a large portion of the folks that are really on the front lines in terms of those the care workers are from a are you know are I guess are from the BAME group, or either black or from, you know, the Southeast Asian countries, correct? Um, but that being said, you know, there's if it's one of the little disconnects sometimes for me is that if these places are so structurally racist and so, you know, so based on, you know, advancement is based on color or whatnot, how is it that, you know, both our countries, the UK and the US, have such a significant portion of folks like you, like me, that are cardiologists, that are physicians? So is it, you know, how do you reconcile that in your mind?
Yeah, I mean, I don't think I'd ever suggest that it's, you know, you know, when you talk about structural racism, um, that can take many forms. So I agree that, you know, there are many increasingly senior um, members of the medical profession from non-white backgrounds. So, and I'm not of the opinion that it's impossible to progress. I think looking at there was a big study, sort of landmark, which kind of launched this as a topic back in the 90s in the UK. And, you know, I think looking back, comparing to then, there's been a lot of progress. Essentially what it said then is that the majority of well, not majority, but a large proportion of the workforce in those less desirable jobs were from Black and Asian and minority ethnic backgrounds. But progressing to senior posts there was more of a hurdle. Now, I think those hurdles do still exist, and the research in the field does suggest that there are still difficulties getting, you know, that based on the proportion of non-white physicians in the health service overall, there is still an underrepresentation in positions of power, but things are improving. So I don't, you know, that would never be my main complaint, really. And doctors as a subgroup, I think, deserve a little bit of individual discussion because they are a little bit different. So I'll certainly talk about that. But when you were mentioning about frontline staff across the whole health service, I think that's when things get a bit more crystallized, because a lot of those jobs are very poorly paid. So, you're seeing across the socioeconomic spectrum then, whereas doctors, we all tend to be fairly well off, really. So I think it's a different set of problems. And a lot of the deaths in the UK, at least, and I'm sure it's the same in the States, have been those lower paid roles. So the care workers and nursing staff who, as you were alluding to there, are at far higher risk than someone like you or me, who, I've been lucky to have pretty good personal protective equipment throughout all of my procedures and cases, and I'm only with a patient for a short amount of time. So that's where I think we've seen a big effect, and particularly care workers are really there's a very I won't be able to give you a figure, but there's a very large proportion that come from who are first generation immigrants who've come to take these jobs from overseas.
So that's the interesting thing, right? So we're trying to connect what's going on in the UK in terms of racism and what's going on in the United States. And there's and the UK and the US are very, very different in terms of where people are in different rungs. So in the United States, the lower socioeconomic strata is primarily made up of individuals of African American descent, of black men and women. That is, and by the way, that lower socioeconomic strata takes the biggest brunt of a lot of things. They have the lowest life expectancy. They have the lowest. They do the worst in terms of cardiovascular outcomes. They have more hypertension, more chronic kidney disease, and the list goes on. And of course, when COVID hits, these are it's not terribly surprising to see that this is happening in that in that group of folks. In the UK, you don't have, luckily, the kind of the deep-rooted historical racism towards Africans that we in the United States have, correct? And the strata, that lower strata, seems to be, and correct me if I'm wrong, seems to be in primarily the immigrant community. A lot of them, the first generation immigrant community, right? So there were three boroughs, for instance, that were especially hard hit. I think Hackney was one of them. Am I getting this right? The London borough of Hackney.
That's right. Yeah.
And a couple adjacent areas.
I can tell you that the worst hit borough is where I'm talking to you from right now. The borough of Newham.
Yes, Newham.
And
right.
the third one was Tower Hamlets.
Right.
And yes, absolutely. There's a high immigrant population in these boroughs. Newham is a predominantly black borough. Tower Hamlets is where a very high concentration of Bangladeshi origin people live. I wouldn't say it's just first generation immigrants. A lot of these socioeconomic factors are maintained. So we're seeing now the third generation of a lot of Asian immigrants. And the interesting, so I guess one of my main messages in that video was, I've always been uncomfortable with the conflation of racial groups with some sort of genetic basis.
Right.
And it's been interesting with a recent review published by the government. I mean, it's interesting we're having this podcast chat today, because just today's news is that part of that review was held back, and it's been leaked now to the BBC. And it was a government review into why minority groups have been hardest hit. And it makes for quite interesting reading, because based on statistics from the Office of National Statistics, Bangladeshi origin people did significantly worse than, say, Indian origin. And I'm from Bengal. My mother's side of the family, they're from what is now Bangladesh. So there's clearly no genetic difference between people on my side of the border versus people on the Bangladeshi side of the border. So this is clearly a socioeconomic thing. And again, Pakistani origin people also came out at a higher risk. And I think, that is a reflection of, as you suggest, the different socioeconomic factors facing these groups. And this pre-COVID, we've seen these same patterns play out. So it's really no surprise that a pandemic, a global health crisis is affecting the same groups that have worse outcomes already.
Right. So why then? And there's little doubt. I mean, there are, yeah, there's certainly no argument there. But why is it that the UK and the US combine to come up with the same narrative? In the United States, it's difficult to suss out because a large percentage of folks that are in the lower socioeconomic strata are Black, and so there's a question as to why exactly that happens. Now, there are of course historical roots for why it is that exists right now. But some of the things that we struggle with, that our kids will grapple with, is what systematically can we do? What structurally needs to be changed now in terms of moving forward, right? Because the theory is that, as I understand it, is that there is still ample things right now that are kind of putting the lid on groups, and at least in the United States, the feeling is that lid in terms of who's being oppressed is done based on the color of your skin. Now, in the United Kingdom, it's not. It appears to be, like you said, when I went and looked at the demographics of Newham and Hackney and that other borough, it appears to be that the folks that are hardest hit are Bangladeshis. They are not, that gradient doesn't hold. Meaning the thing that's common between the UK and the US in terms of who COVID is hitting the hardest are folks that are in the bottom rung of that socioeconomic strata. These folks, not unsurprisingly, because they're in that rung, live in densely packed areas. They're not living in suburbs with large single family houses. So there seems to be they can't work from home on the internet, right? These are folks that are working on the front lines. So Rohan, how does one come out with a narrative that this is somehow an example of systemic racism, unless you want to say that, that socioeconomic, that society that kind of stratifies itself since whenever by certain socioeconomic classes is racist. Meaning, do you understand the confusion?
Yeah, no, I mean, I think we're probably agreed on a large part of this, that it's not somebody's race that has made them susceptible to being worse hit by COVID-19, but where they find themselves in society. Now, I mean, I'm not the person to ask. I have no specialist knowledge about wider economic factors, but while some of these people are new to the country and have come to fill a demand that we have here for certain types of job, a lot of these people have very little way out of the position they find themselves in, and there is far less opportunity for somebody living in an inner city housing estate in one of these boroughs that we've mentioned. Their education is much worse. As we've mentioned, their health outcomes are far worse. So, it's, I mean, again, this is a sort of wider discussion, but the communities that are hit worse by those lack of opportunities do tend to be from minority ethnic backgrounds, and I mean, there are clearly poor white communities in these same areas as well.
Right.
But even looking at those, their outcomes don't tend to be as bad. So I mean,
Yeah. Could there
again,
be
I'm no
right?
expert here.
Yeah, yeah. I mean, but you know, just from our experience in the U.S., right? There are poor white individuals that live in inner cities, but a lot of poor white individuals in the United States, it's more a rural poor situation. So they're more
Sure.
spaced out. They're not densely packed and stuff. You know, it just comes back to this one of these themes that I don't understand why. You know, society's complex, answers are complex. There's a lot of nuance. I don't know why simply disparities in outcomes necessarily comes down to saying it must be color. I mean, it seems like if you're in a lower socioeconomic strata, you live in a small and you're living in an urban center, you're more densely packed. You know, you don't have the type of opportunities that that other people have that are born elsewhere, that are born in other, you know, to wealthier parents or whatnot, is what I mean. And so it's just, you know, that's why people end up doing worse. I The other you know, uh, in terms of you brought up the point about personal protective equipment. Why is there a reason why is it that the frontline workers aren't getting what they need?
Oh well, I mean, I think there's been a very poor response to the pandemic from our government. You know, the fact that only yesterday Brazil, which is a far bigger country than us, has overtaken us and gone into second place for overall deaths. We were in second place behind only the US for weeks in a country of 70 million people. It is a reflection of how poor I think the government's response has been, and part of that has been a lack of preparation from top down, from the government to the NHS. I think at a hospital level, it's hard to fault. Actually, I think hospitals really kind of turned everything around and made huge adjustments. Now, the knock-on effects of all that, you know, we're just still finding out. But yeah, I mean, one of the main things has been a lack of PPE, and I know America's had a similar kind of problems. I'm not a subscriber to the, you know, I think it became a bit of a mantra, and you know, I'm not putting all of my anger into this one thing, but I think it was reflective of the lack of support that the government gave us.
It's funny. And again, these are not these are not meant to be gotcha things at all. It's just it's funny when I saw, you know, similar problems in the UK system as our system, meaning we seem to be struggling with a lot of the same things. I saw your tweet earlier today arguing that it may be the populist
Well, I said that I actually gave you
Bolsonaro.
a pass. Yeah, I gave all the other countries. I said they're just bigger countries, so they're going to have more cases.
Yeah. No,
so it's really just the UK that's the odd one out on that list.
Right. I liked it though. The Bolsonaro, Trump, Boris Johnson, and Mr. Modi. All four you know, have pretty high.
Somebody suggested maybe it's just the bad haircuts that's a common factor.
I think so. I think it may be you know, I'm surprised that the yoga that Narendra Modi is constantly tweeting about is not keeping COVID at bay. I'm gonna
or the cow urine.
Yes. Where was I before I got lost on that? You know, when we look at the problems that the US is having, being very similar to the problems the UK is having, right? The disparity in outcomes by whatever strata, but actually by socioeconomic strata, both in the US and the UK, trouble with PPE. We need more ventilators. Mr. Trump was especially excited to keep saying. I felt bad for the UK a little bit, because he kept talking about how Boris was terrified about running out of ventilators, and he was making these ventilators so that you know, to send to his good friend Boris. Isn't it? Do you find it surprising that even though our systems of healthcare are so different, that we still struggle with the same problems? What does that tell us, that if the UK with a National Health Service still has a significant gradient in terms of their worst boroughs and their best boroughs, and the US has some gradient, is it really the health system that's the differing thing there?
I mean, I think the key point behind to bear in mind when answering a question like that is that the NHS is in a very sorry state at the moment, because it hasn't been adequately funded for over 10 years now. And while our systems are very different, I think our leaders are pretty similar. And I think our governments at the moment are similarly aligned in some of their sort of policies. So, I suspected that you might ask me about the NHS, knowing you, and I am someone who believes it needs a lot of reform, and I'm not one of the. I feel like sometimes it's kind of fetishized in the UK, and it's become a kind of pseudo religion, and it's difficult to have conversations about what to do regarding the NHS. But I think in this particular regard, I certainly would defend it, because going into all of this, there were almost 50,000 nursing posts in the UK unfilled. The doctor figure was something like 17 or 20,000 physician posts that are unfilled. I mean, in every hospital I've worked at, we've had gaps on our rota. So this is not the NHS as it should be functioning. And we know that it can be better, because previous governments have given it more money. And I'm not aligned to any political party. I've got no bias. At least I try not to. But it's been clear that it's been massively underfunded. So we were going into it with a lamed health service, and I as a result, we've been very poorly prepared. America, obviously I've followed what's happening there to an extent, not as closely, and there have been different challenges. I think one strength that we've had is we've been able to do research across the whole NHS. We've done a huge trial into one of the drugs of the moment, hydroxychloroquine, because of our national system. So that 10,000 people or so were recruited into that in a short space of time, which is something that just would be much harder to organize in a different kind of system. So I think I certainly would defend the NHS on this one.
Yeah, it seems so. I think our systems are a bit more similar than folks usually will say, because the United States spends a ridiculous amount of money on government-funded healthcare, right?
Yeah, the highest.
I mean, our mechanism of right. So just the UK taxpayer pays a certain amount towards to fund the NHS, and the United States dwarfs that. I mean, it's a much bigger country, I know, but the United States dwarfs that easily based on what it spends on its senior citizens. So if you're over 65, you get Medicare, and that's covered. The people pay a reasonably small amount per month to kind of flesh it out. And then Medicaid, for folks that fall below a certain number in terms of the poverty line, is also funded to a significant amount. The United States, so combined, the Medicaid, if federal plus state, so taxpayer stuff is for the poor, is $500 billion a year, and it's about that much, or maybe $600 billion now a year, that we spend on Medicare. So we're spending almost $1 trillion a year on a government-funded healthcare system here, and over time, if you look, certainly we've gone from in 1965, 5% of the budget, 5% of the GDP used to go to go to kind of government-funded healthcare, and now it's up to, it's approaching 20%. It's 18% last we looked.
Yeah.
The NHS has a similar trajectory though in terms of funding, and it's very hard when you look at the funding, funding for the NHS. It's very hard to see any interruption because of the various Tory governments that want to limit it or whatnot. So in 1955-56, I think 11% of the public service budget went to the NHS. In 2016-2017, 30% of the public budget went to the NHS. So how is part of the, what does one, how does one move forward given that? Meaning, whether you're a Labour politician or a Conservative, a Tory politician, part of their problem, right, is that the health service sector seems to be consuming an ever larger percentage of the health service budget. Where does that money then end up coming from?
Well, tax, I guess.
Yeah, tax more.
I think one of the key strengths that the NHS had, which it's gradually eroding voluntarily, is being this behemoth of an entity. So it could negotiate the cheapest deals for drugs, for therapies, for equipment that, other health systems, if you're a big hospital in America, that's your bargaining power. Whereas this is an entire national system. So we've always done very well at getting good value, but as we're outsourcing more and more, and again, this is, coming back to what I was saying about the British sometimes treating it like a religion, is a lot of people don't realize there's been a large degree of privatization already within the NHS. And so a lot of the funding streams are now sent out to the private sector. And of course, those costs tend to spiral. And so it's becoming less and less cost effective. And I think, I'm not I don't have any particular strong feelings on the kind of general privatization of public services argument. But I think for the NHS, it was such an important factor in its initial success that it was able to set all the prices, that it was able to do things in-house. And that's another point, I guess, is it started doing too much. And I think the NHS is it's not feasible being all things to all people. And it's natural that it will increase as a percentage of GDP spending, because we are getting older. There are more and more people who are not working, who are old, with increasing complexity of health needs. And even just in one generation, talking to the older generation of doctors about the kind of patients that they saw, they're far more complex now. So it's inevitable. And I think you're right that both trajectories are heading up. But if you compare spending with similar sized European countries, we're fairly comparable. In fact, lower than some of our neighbors who have partially privatized or insurance-based systems. Right. So again, I don't pretend to understand these things very well, but I'm not sure that I still believe that the NHS can continue as something that's free at the point of access, that's taxpayer funded. But I think it does need some wholesale changes.
Right. It's always super interesting to me, because I feel like regardless of what ends of the spectrum you come from when it comes to healthcare in these systems, UK, US, elsewhere, I guess the Germans have it figured out. The Germans have everything figured out all the time. They make these ridiculous cards.
The Germans make us look bad on a regular basis.
Both of us. But yeah, we seem to struggle with the same issues. We both want this more efficient healthcare system, et cetera. And I think I've kind of progressed to the opinion that I just can't see bureaucrats. Yes, Minister, what a wonderful show, and it so classically demonstrates the incompetence.
Yeah, it's still so relevant.
Right. So to me, it's like, how exactly are we going to get a more efficient healthcare system when say, hey, dear bureaucrat, make this more efficient, But then the other part of your video, which was also, now you touched on some of the, clearly the deeper reading that you've done. I actually went and picked up Angela Saini's book. Well, I got it on Kindle. Superior, correct?
Mm.
Is the name of her book, and it's an interesting book. It's structured as a series of interviews with a variety of different researchers, right? There's David Reich, there's Richard Heyer. These are pretty prominent folks, and it looks at one of the foundational premises is that since racial categories have no relation to biology, they were basically created by whites as a means to enforce oppression of other groups. So basically, you're socially engineering this white race to act as a ruling class. That's kind of one of the main theses of her, that she's kind of getting at. So a society with um, basically arguing against this idea of there being any type of genetic determinism. And certainly she very nicely lays out the multiple different times in history that idea of genetic determinism has been used in a very terrible way, to kind of rationalize all kinds of horrendous things, Adolf Hitler being a prime example. So she said, so essentially race is not a meaningful biologic category, as you would agree, one of her
Yes,
major
I would
theses.
agree. Yeah.
Why exactly, why should we in medicine, I mean, she's talking about why should we in medicine necessarily agree with that? Let me flesh it out a little bit before I ask that. The idea is that we have, when humans began leaving Africa about 75,000 years ago, they dispersed across this greater range of environments that they hadn't inhabited before, right? So they were all genetically similar, and they went all over, the variety of different environments that they went to. And so they came under very different environmental selection pressures. So why over thousands of years? Oh, and by the way, then you had, these natural barriers that kind of kept those communities apart. So when you have a limited gene flow, you have different environmental pressures. Why over thousands of years would you not get populations that are distinct in one way or the other from others? I mean, isn't that so? Whether you call it race, I mean, I don't know what. I mean, maybe race is just such a pejorative term now that we should adopt some different term
No,
for it.
I don't think it's a case of it being a pejorative term, and I hope I never
Yeah.
come across that this is some sort of oversensitivity or anything. Certainly, there is genetic variation around the world, but it doesn't tally up with our social definitions of race. So, Hispanic, that doesn't really mean anything, and black again is a kind of meaningless term, because now a lot in the US, black African American, the majority of people in the US who are African American came from a fairly small, well, I mean, Africa's a massive place, but a small part of Africa, from West Africa, and you had a founder population coming to the US from a genetic point of view. I mean, and so you could argue that there's less genetic variation there, but in the UK, where we have the same hypertension guidelines, which just state that under 55, black or white, gets a different medication, and that was something that even back in medical school struck me as being a little bit odd, because somebody from North Africa who is classed, or sub-Saharan Africa is classed as black, or someone from South Africa is likely to have more genetic variation than someone from Alaska and someone from Australia.
Right.
So I just found that the definitions that we use are not particularly useful. To come back to your point about wouldn't there be genetic variety over thousands of years? Yes, there is. It's much less than I think we all assume, because we're a kind of very visual species. We we judge people based on how they look. I don't mean that in a kind of negative way, but the way someone looks is very important to how we treat them. And so we assume that these very obvious differences between how we look also translate to how we are inside. And it is such a kind of almost common sense belief that it's quite difficult to challenge. And that's really, I think, the point that Angela's making in the book. And one of the chapters does sort of center on medicine. I wish I had sort of looked into the background reading a bit more in preparation for this, but she comes on to talking about medications that were marketed as particularly useful for the Black community. Bidil, which is a isobutadienitrate and hydralazine combination drug, and how that was really based on pretty shaky evidence. And I've started trying to look into the basis for some of these medical guidelines about why we do differentiate between Black or South Asian groups, and I often it comes out pretty nothing much there. And I'll need to go into this in a bit more detail. I'm still quite new to learning about this myself, but some of these sort of the belief about ACE inhibitors being less effective, it was somewhere in the region, I don't want to make up numbers now, but the number needed to treat for a white population was barely different to the Black population. And in both cases, it wasn't particularly impressive anyway. So you're looking, in terms of relative risk reduction, it's really not that big a difference. And yet we've made whole guidelines based on these very small differences, which again, could be affected by many confounding variables, like all the things we've discussed before. Even when those are attempted to be corrected for, when people have attempted to correct these factors, we're seeing actually the differences kind of disappear. So that was really, I think, why it is still relevant to medicine. And one of the kind of points I make in the video is that I don't think it's useful to say race doesn't exist at all. Race clearly is an important concept for many reasons, but in biology and medicine, I don't think it's very useful. There's a move to personalized medicine these days, and it's a big buzz phrase. And so, again, I don't want to give the impression that it's just the white population that are maintaining these barriers. A lot of the time, it's actually people from these communities who are trying to give a better service to their other Black people or other Asian people who feel that they are, trying to make more personalized medicine directed at their community, but actually it's based on pretty faulty science.
Yeah. So one of the really interesting things about the book was, again, something I didn't know, and you introduced me to it, was the idea of this idea that there's a lot more variation within a population. You made the point that Africa is a very large population. Why do we consider Africans, say, different than white Caucasians? Correct, because within Africa there's such a vast variation, and it's based on I'm going to mispronounce his name, but somebody named Lewontin, and he kind of noted the amount of variation in any one genetic locus was greater within a population than between a population. But that's also, and she doesn't talk about this because, or at least I didn't see it, but she, there's a little bit of a fallacy to that, because as you're saying, it's hard to not see, since we are visual, it's hard to not see that visually, at least, it appears that there are distinct biological differences, and so this whole Lewontin, there's a Lewontin fallacy, and the mistake is that you're taking one specific locus. The mistake is to take one specific locus rather, and taking multiple correlated differences across many loci is a better way of doing it. And basically what that means is that, obviously, if you look at men and women's faces, if you take any one particular characteristic. If you take noses, say, right, there's a lot more variation, within a sex than between the sexes. But that doesn't mean, but you would never use noses alone to distinguish men from women. What it is you take the entirety of the face, the jaw, the jawline, etc. A bunch of different things to kind of distinguish male from female. So I mean, that's how we experience faces. So at that point, the differences, when you take everything, the differences become clear enough that you can kind of start to distinguish male from female. So I thought it was really an interesting book and historically great. But but then when I started thinking, just like you are, about the applications within biology, Beidel is a great example. You're right, but one of the more, that relative difference seems to be relatively small. But we're told all the time, that in public health, if we treat vast populations, then those small differences start to accrue. But the other thing that came to mind was the recent controversy regarding estimating your GFR, correct?
Mm.
So again, this is where I just want to be sure that we're not letting political winds or kind of displace what is medicine, right? So to me, the GFR things, in talking to some of the nephrologists and reading some smarter than me, reading their blogs, it seems to be that you had a curve fitting exercise here in terms of you had actual GFR, measured GFR in whatever difficult way, versus trying to estimate GFR off of a spot creatinine. And it seemed that this MDRD group in the late 90s, simply said, well, it looks like we'll be able to fit our curves better if fit the curve to the dots, the data points better, if we use this this different constant, essentially. And that's what made this and it wasn't them saying, this is who's black, this is who's white. This is people who self-identify as black, if you will. So if that estimate is going to give you a better idea of what their real GFR is, then what's the significant danger there? It gets to the male versus women too. Like one of the things in cardiology that I'm much more well versed with is this idea of not ignoring women with symptoms because their symptoms will be atypical. And there's this whole data set that's emerged that suggests that we are not doing as well for women with coronary disease as men are. But lost in all that is the fact that men do way worse in terms of coronary disease than women. I mean, if you look at the mortality tables, I mean, it's like 2 to 1, 3 to 1 in that age group from 35 to 65. At every age stratified spot, that difference, male versus female. Now, again, we're in a world today where that question of what gender is maybe it's biological, maybe it's not. Is it a social construct? What have you? Gender fluidity and whatnot. But for whatever it is, for people who self-identify as men and self-identify as women, you have a pretty significant marker here that tells you, hey, this person is way riskier in terms of them having a future cardiovascular event, and perhaps we should then target this group, more. Meaning, so in that same vein,
okay. So I think there are a few issues that are I think being a bit conflated here. I would agree with you that I think we don't want to ignore science for the sake of being woke. Right? I think
right.
We're on the same page in that this is not an exercise in just trying to be as we're trying to prioritize the science. But difference between sexes, again, just simplifying things and just talking about genetics, there's a clear, you can look down at a chromosome and see a male chromosome versus female, whereas that doesn't exist in race. There's nothing. Even if you were to take the entire genome, there's no marker. No matter how many loci you look at, you won't be able to. You can make a guess, based on things like melanin expression and so forth, but there is no genetic marker of race. So I think the comparison to sex is not valid, because that's much more clear cut. And I think the intentions are entirely noble and sensible. And as you say, you're trying to apply to populations. But I've not been convinced that the benefit from these kind of blunt tools, in contrast to something like sex, where I agree. I think one of the things that was lost in the debate about women presenting with heart disease was that the majority of women still present with typical symptoms.
Yeah,
and
exactly right.
these atypical symptoms is actually just a small percentage of women as well.
Right.
And there's also a small percentage of men that present with atypical symptoms.
Right.
And I think maybe it was slightly kind of, I don't know how, the message got a bit twisted, but actually the majority of women present with central crushing chest pain. And so, we can exaggerate some of these differences to suit a story, whether that's done deliberately or not. And again, I think that the differences between races in a lot of biological outcomes is not that significant. And if there was I mean, again, I'm more familiar with cardiology than nephrology, but my fear is that a lot of the, and again, I don't at all mean to accuse only white people of doing this. Just today, with this BBC review on minority outcomes in COVID, just today, we had one of the most senior doctors in the UK, who's of Indian origin, saying things that don't make biological sense. He's saying, people of BAME backgrounds are more likely to die once they catch COVID-19, which is fundamentally misunderstanding what the statistics are showing. Is the difference between case fatality and population fatality. So actually, the stats suggest that once you have COVID-19, your outcomes for hospitalized patients, we don't have the data for the mild cases, but for hospitalized patients, the outcomes are pretty much the same, irrespective of racial demographic. It's age that is the main thing. So again, I don't want to over exaggerate some of these differences. And my fear is that by talking about these and saying that this group is going to do worse with this, is we're cementing the idea that we are fundamentally different at a genetic level, which, maybe that is coming back to your point of social concerns clouding the picture. But I do feel that it's a very real concern that if scientists and doctors are talking about different races like they are completely different biological entities, for some marginal potential benefit of giving this drug or calculating an EGFR in a slightly different way, when it hasn't been shown to make a big difference in outcomes, I think then that is the wrong kind of priority.
Yeah, no, that's very well said. It seems to be the case that if we that a lot of, I think it's well intentioned in that, or some of it is well intentioned in that you're trying to target populations, maybe taking a charitable approach to the senior, whoever the senior person was that you were referring to. Do you think a reasonable approach would be to say that, okay, we should be targeting whole communities that, so for instance, if in the United States, we know the zip codes in which there's a particular significant mortality rate, and these folks do really badly. And again, I don't think it's I don't think it's race based. I think it's I think it's based on the fact that, as I brought up earlier, that I really think it's socioeconomic strata based. So if you're in a low socioeconomic strata in the UK, your living conditions are similar to that in the US. And those things that, the virus does not care about, right? The virus loves, these densely packed, the virus loves to spread in these densely packed areas. And so it wouldn't be unreasonable, say, for instance, to target those areas, those zip codes, not by race, but just those zip codes, because there's a bunch of folks living there of all sorts of ethnicities and whatnot, with, say, things about mask wearing, or hand sanitizing your hands, or whatnot. Correct. So there's no that would be what you're talking about, as opposed to saying, oh, this is just an ethnic thing, and that's why, therefore it's okay. It doesn't mean that we don't need to keep pushing for kind of change. It would be your point, I guess.
Yeah, I think, as I said, I think we're agreed on that. Whether you want to, because a lot of these Venn diagrams overlap, don't they? So if you're saying healthcare workers are at higher risk, and then you're saying a lot of healthcare workers are from ethnic minority backgrounds, clearly there's going to be a big overlap between those two groups. So however you want to tease it out, we know who's going to be at a higher risk.
Right. But don't make the distinction by color, or skin, or race, or whatnot. It would be
I think that's
the major point.
One of the least useful.
Yeah, and that's the thing. As physicians, I feel like this is partly why, it's kind of this thing that has been in the background. I trained in North Philadelphia, which is a really, really poor part of the city, and there's a significant African American population there, and it just never entered my mind, as a young man training there. I just, it didn't, I just never thought of it. It's just, you treat the individual in front of you, whether that person is Korean or Chinese or white or Indian or black. And for a lot of us physicians, I think, I feel like that's how we operate. I mean, we have in our heads, we have this idea that, okay, men have a higher proclivity for having this, or maybe we have it in our head that Southeast Asians, for instance, have a, whatever, have a more malignant CAD at an earlier age. For maybe it's that eating too many Bengali sweets, probably.
Well, I mean, that's a very good point, right? So we joke about it here. We say that Indians, you're not going to escape diabetes. We're all going to get it at some point. But it's not because we are Indian. It's because Indian food tends to be more diabetogenic.
But but Rohan, if it was the case that, I mean, we can never tease out for sure. It doesn't. My point I was getting to was, it doesn't even really matter. Maybe it's the case that the Punjabis have some weird gene that causes earlier CAD. I mean, as a doctor, my point is that, okay, maybe this is something we notice, but when a Punjabi comes, when a Punjabi individual comes to the office, whether I figure that out or not, you still treat him. You're still trying to figure out, is his chest pain cardiac? Is it, what type of studies do I send? This subtle thing on the EKG. What is it? To us in medicine, I feel like, at least not to some public health person who sits in the ivory tower and is kind of trying to come up with some vast system for populations. For folks like you and me, it's the person in front of us, and in our, in the back of our minds, because we're human, we have some general preference. So, for instance, the individual who was in my office, who was, father of someone or the other, who, we're talking about cardiovascular risk stratification. When I walk in, he's telling me, he has that Indian, he's like the Indian dad body. Actually, I'm now an Indian dad, but 30 years from now, the Indian dad body that I imagine I'll have. Clearly, the man has lived well and has eaten his share of stuff. And so, he was telling me what he was eating, and it sounded like, all he ate was like celery and vegetable. I was like, come on, uncle. I know you must love your wife's aloo parathas. And he laughed and was like, every morning I wake up with some nice butter, some aloo paratha. I can't give that up. So, but that's not me. I mean, that's not me. I mean, I view that as in some way, like, of engaging with him, right?
Yeah, no, I mean, that's fine. But,
Yeah.
Obviously, culturally,
Right.
there are huge differences between
Right.
groups. And I'd
Right.
never try and
Right.
argue against that.
Yeah.
And cultural awareness, diet,
Yeah.
lifestyle, smoking, all these things vary wildly between different groups. And
Yeah.
medicine is very much a process where, we're constantly trying to narrow down our differential based on all the factors in front of us. And the Royal College of Physicians here, which, the exam to become an internal medicine doctor, it's a gag amongst us that you can guess the diagnosis from the first line. So, it said a South Asian man. It used to always be TB, and now I guess it would be heart disease. But and then it would be a businessman goes to Thailand and it's HIV.
Right.
And so, we're brought up with these kind of stereotypical views, and a lot of the time you can argue they'd be helpful. But the problem is that I think we overestimate our ability to avoid implicit bias. So, and this is a commonly cited survey that was done in the US. I don't know who they surveyed because some of the views were completely bonkers, but they were talking to medical students, and some of them believed that Black people didn't feel pain in the same way, and their skin is different. It's thicker, so you don't need to give local anesthetic, and all these kinds of bizarre beliefs amongst medical students. And so I think we have to separate the cultural sensitivity and the cultural differences that exist, which can explain a lot of these health outcomes, from believing that it's some sort of biological difference. So yeah, of course, we're always going to use tools, and we'll try and treat the patient in front of us to the best of our abilities. But I think we have to be very conscious. Well, I mean, by definition, we can't be conscious of unconscious bias. And that has been shown to manifest itself because Black patients in America get different amounts of psychiatric medication prescribed, different amounts of opiates prescribed. So, it's very hard to avoid, even if we think we're being absolutely objective.
Right. And I think it's hard to tease out too. Meaning, we basically, any disparity in outcomes that happens, we seem to land on what's the most convenient thing that it could represent. And this is where we made this. I don't know that every single disparity that we have represents some type of systemic badness, if you will. There are things that are like, that doesn't mean that there aren't. Like what you described, you described some stuff perfectly. There are biases that we hold, and we have to constantly struggle against them. And that's why your video is really good, because it's self-reflective, and doesn't just say, hey, this isn't a problem that affects me, right? We should all constantly try to look inwards and figure out what's going on. I just I get a little frustrated with the fact, with every single disparity being seen as some type of, like, I'm not, it's not, and I fully understand that this may not be perceived well, but like, I don't think it's systemic oppression that is keeping Indian men from the NBA. We have to. There are problems in society. We have to keep struggling to try to get better. But it is probably the case that for whatever reason, whether it be cultural, and I'm saying even if that is genetic, it doesn't. There are simple genetic differences that do come about. It wouldn't be surprising to me because of our origin story. Like, I mean, the fact that we're different colored skin happened because some people were exposed to a lot more UV for a lot longer period of time. So would it be that shocking to me if somebody found some gene that had a relative risk of 3 or 4 in terms of developing chronic kidney disease? If there some population, I'm not saying any, I wouldn't be shocked if that were
Well,
to
I mean,
happen. But in my point, I'm just saying it doesn't. To me, as physicians, as long as we keep struggling internally to try to overcome biases that are negative, right? The bias about me asking, uh, you know, Punjabi uncle about his aloo parathas is obviously not something that's bad. There are other biases that are bad that we need to kind of struggle against. But to me, how does it? It shouldn't. Hopefully, it shouldn't matter to us. We, as physicians, need to try to do the best we can for the person in front of us, regardless of what color skin they have or where they come from or what zip code they come from, and that's kind of the ethos of medicine. That's partly why I love medicine so much. One of the brilliant things, coming from India to here, for me, was that I was always so amazed that, like, the individual that was homeless, that was poor, that was an ER Bay 1, every single medical student, etc. Dear Mr. So and so, what can we do for you? There's at least from a physician side of things, there's a tremendous amount of respect that I find existed here in the United States, as opposed to on my on my experience with healthcare and in general life in say India, where it seemed like the value for each individual life was so small. It wasn't like nobody would blink an eye for rejecting somebody who was in severe abdominal pain, saying, sorry, no beds here, go on. Or if you couldn't pay for a certain type of stent, it's like, well, I'm sorry, I guess we can give you TPA. So um that's one of the brilliant things about the United States when I got here, and then my experience for a long time was that that regardless of what color, how poor they were, how rich they were, the person in ER Bay 1 seemed to get like that, seemed to get a certain level of respect. Now, as I got older and experienced the system more and learned more and more, and the studies you're talking about, there's certainly examples where that I wasn't aware of, that there still are significant differences.
but I mean, you can't tell me that it's like maybe ER Bay 1 because that's the emergency department, but you can't tell me that the rest of the hospital is you get the same level of care irrespective of your income or your insurance.
Yeah. Well, I was surprised by the floor. The floor is very, very impressive in the United States. Meaning the floor, insurance, no insurance. This is one of the things I think a lot of British citizens may not realize, is that certainly for any of these conditions, for any emergent condition, when you come in, the ICU bed that the CEO of the hospital is in, right next to him can be somebody who's uninsured, right? So if they both have a subarachnoid hemorrhage, and they're in rooms next to each other.
They'll get billed for it eventually, right?
Well, no, I mean, there's that. That's why hospitals write off a ton of stuff, right? So you don't, so you don't even try. Like I've never sent a bill to an uninsured person that I've seen, and that's probably the case for most people. I mean, from a business, forget the whole ethical standpoint. From a business standpoint, it doesn't make a ton of sense to try to collect from somebody who's homeless, but or somebody that's of low means. But no, I mean, we have lots of problems. There, that difficult issue is those folks that are underinsured. I think those are the folks that carry the biggest burden, and they will get hit with these bills. And Marty Makary, who hopefully will get on the show at some point, he's a Johns Hopkins surgeon, tremendous amount of work kind of shaming these nonprofit hospitals from saying, why are you suing these poor people in court for these ridiculous type of bills? But I'm just relating that certainly to me, one of the amazing things about the United States when I came here from India was how it is, how equal everyone's care seemed to be. And you're right, that floor of care is what's very, very impressive. That same homeless person trying to get say chronic disease management type stuff, that may be more difficult and whatnot, certainly. But
I mean, I would argue that the floor should be impressive. You're the richest country in the world, so I think that is how it should be. But thereafter, or even before that patient reaches the hospital, you were saying you want to treat the person in your clinic room the same as anybody else, but it's accessing that healthcare in the first place is the first obstacle, and particularly when we're talking about immigrant communities, a lot of them are less aware of what is available to them. There may be language barriers, and then beyond that emergency care, sort of ongoing care, that, you know, that there is a big
Yeah, no, that's a
drive.
longer conversation in terms of,
Yeah,
and
that's
that's
a
one of my
different conversation.
frustrations is, you know, we spend $550 billion a year, Rohan, $550 billion that the U.S. taxpayer pays for covering people that are that are fall below a certain poverty line, right? I mean, so and yet the vast majority of that money, and this is where we see clearly eye to eye, the vast majority of the money goes to managed care companies that are in blocks and blocks and prime time real estate, and you know, all they do is not make it very easy for those patients that have signed up to this program to deliver care. So it's
Mm.
basically a massive, you know, siphoning off of the taxpayer
Yeah.
dollar to these corporations that then, you know, when I try, and I still take Medicaid and uninsured, we have an uninsured rate, blah blah blah, but my point is, when I try to take care of these patients that are on Medicaid, you know, severe back pain, you know, they need a CT because their specialist said it. You know, we know companies, and the first thing is always to deny, tie
Mm.
us up in prior auths, and they don't pay us a significant amount for those patients to begin with. So then now you have all this work to do for someone who, you know, and so someone who, you know, the remuneration is going to be incredibly small. So you know, and I think the Medicaid insurers, you know, they know this at some level because they're primarily businessmen. But anyway, that's a longer conversation about healthcare access and how to improve it. I think the way I think of improving it is unfortunately now much different than what I thought, you know, a while ago. But this has been, Rowan, been a fantastic conversation. Thank you for. I'm sorry, I'm running over for you.
No, no. Thanks very
One
much for
last
inviting me.
one last thing. What, in terms of, can you leave us with some hopeful thoughts in terms of how you think all of this may get better within medicine? Do you think there are things that the medical community here is going to learn, and if so, what are some things that you think um, we can do, or what are some things that you're seeing done that will hopefully put us in a better place?
Yeah, I mean, I think I can look back to right at the start, really, when you were sort of asking about how a brown person has done okay in the health service. And I think with everything that's going on in the world right now, we've maybe been a bit introspective and seen that just because there are a lot of Asians in medicine, that doesn't mean that we're post-racism. And actually, I was trying to think about the amount of black cardiologists that I know, and I could name about 3 out of everybody I know in the UK. So there's, I think, a greater understanding. I mean, I think Britain's always struggled with this, that British people feel that racism's not a current issue. It's something that we've got over. And so I think that we're, you know, more aware of certain disparities that exist. I think the main sort of topic we've been discussing, I think people are increasingly aware that some of these categories are blunt tools, and you know, we need to be a bit more refined in how we are talking about different populations, and maybe trying to individualize risk more than just use very broad strokes. In terms of things we can do, I mean, I don't know, but
Well,
I guess just try and be conscious of some of
yeah.
these issues.
The Indian male cardiologist in the United States is highly overrepresented, right? Indian Americans are 1% of the population, and I'm making up this number, but it feels like, certainly from Twitter, I don't know, it feels like 80% of all cardiologists are Indian
I mean,
males.
I think cardiology in particular in America is
Right.
very highly there are a lot of Indian guys, right? And
a lot of Indians.
One reason that was given to me once is because it is such a punishing career, and you know, very long hours and competitive. This was an American telling me that they were saying the caliber of applicants from overseas is, because you've got the whole world applying. I mean, India alone is producing tens of thousands. Is that it's really hard for a lot of the American graduates to compete with some of these people who've got incredible CVs, and they feel that actually there are careers that will give them more satisfaction with a less intense workload. And I
Right.
think maybe, and that was the reason was given to me is that similarly to the low-paid jobs in society, is that it's actually immigrants that are willing to put up with these kind of working conditions. But yeah, I mean, certainly I agree from Twitter that,
So
the brown male is very
so it's in
highly represented.
yeah. So it's interesting to me, and a lot of them are first generation. I mean, I'm like you. I came here when I was, reasonably young, so I'm kind of a mix. But I'm still considered an immigrant. But a lot of them are, that second generation or sorry, that first generation of
Mm.
Indian Americans. Um, and it kind of feels like one of the big issues in cardiology is that we're not diverse enough. And to me, I was like, holy cannoli, we are like, it seems like we're super diverse. We have tons of lots of Asians, we have lots of Indians, and that seems that like that should make things diverse. But that's not enough, I guess. And as you're pointing out, there are only 3 black cardiologists. The number of black cardiologists are relatively small. The number of female cardiologists is also relatively small. Um, Without expanding the pyro, and this means it's going to get ever harder for young Indians to ascend and become cardiologists. Is that yeah, because it seems like you rectify these things the way people have rectified it in other areas, in some type of affirmative action or some type of quotas. India has lots of quotas and what's called reservations. Um, is that is that is that is that a constructive, productive way of doing it?
I mean, we've never used quotas or
Mm.
affirmative action really in the UK, and I'm quite happy about that. And I think our strategy um, has been more of a nudge. So maybe just trying to ensure that at least the interviewees are more diverse. But I mean, yeah, I would disagree that it's going to get harder for any particular demographic. I think just expanding opportunity and equality doesn't necessarily mean that it's going to get harder for any particular group. I think that at the end of the day, there's always a lot of luck involved with these things.
Yeah.
And generally, people who want to go into cardiology get to do it eventually. It may take a little longer to get in.
That's a good point.
But out of my peers, everyone's got there in the end. Maybe one or two have decided something else.
Right.
And a few have left having got in. That's a different story. But I don't know. I feel optimistic about
Good.
Equality of opportunity once you're in medicine. Getting into medical school and things like that, that's a much wider debate and really comes down to schooling and all those
Right.
things we talked about. But
Right.
but I think once you get into medicine, I think it's getting more level as a playing field.
Good. Well, Rohan, the one thing that makes me optimistic is people like you. You're I think a shade, or maybe more than a shade, younger than me, and it's wonderful to see young bright folks coming up. So it makes me super optimistic that that things are headed in the right direction if we keep getting great talented folks like you in the field. So I think medicine needs folks like you who are kind of talented in multiple different arenas. It's no longer the fact that you can be a fantastic physician only if you're a great if you have great bedside manner, etc. I think
I think that's become the least important skill
yeah.
these days because you can't put it on a CV.
No,
You
it shouldn't be, but that there's always going to be value for that. But if we're ever going to, as a group, I think get better, it's going to and have our voice heard in a different way. It's going to take advocacy that's a little harder, I think, now than it was before. Things are flatter in a way in terms of, you having the platform that you have, but you didn't get there by accident. I mean, your platform is built based on, charisma, personality, your ability to communicate, and so we need really talented people to do medicine. And one of the fears I have is always that, the harder we make medicine, or the more challenges, the more obstacles, the more scut work, that type of stuff that doesn't make you, at the end of the day, doesn't make you happy.
Yeah,
We're not going to keep
I agree.
getting the best of society, as I'm biased, the best of society as we seem to have for ages and ages. But seeing folks like you, Ron, always makes me happy. So.
Well, I agree with your point that there does seem to be a lot of low value work that can put people off. But thanks for your kind words, and it was a pleasure to chat.
Thanks, Rowan. Alrighty, and we are.